Hi and welcome to Pulmonology Read Aloud. I'm Dr. Ansha Maneja Arora. I present pulmonology articles, papers, topics read aloud to you so that you can listen to them on the go and stay updated. If you haven't subscribed to my channel, please subscribe, like, and share this channel. Today, we'll be talking about progressive pulmonary fibrosis expert group consensus statements. This is in continuation to my previous video, which has been attached as a link here, and you can go and refer to the video as well. So, we'll be talking about PPF. Let's get started. So, this expert consensus statement, just recently published, is a statement by a multidisciplinary team of 21 ILD experts, which was published in the European Respiratory Journal. This team consisted of 15 pulmonologists, two palliative care physicians, two radiologists, a pathologist, and a rheumatologist. And because it was an expert consensus statement, they did a exhaustive search of the related topics. They asked a lot of questions. They searched the keywords online and prepared a summary of what is the consensus on how this has to be practiced. They stuck to four main sections here. One was to define how to diagnose PPF for progressive pulmonary fibrosis. Two, how to monitor prognosticate. Three, what is the treatment and the combinations. And four, is there something else which can be added as a supportive care? It's very, very clear when this consensus statement starts. They have repeatedly mentioned that this is a consensus, it is not a guideline. And this shall be revised when guidelines come, and guidelines will hopefully give us more evidence to support everything that's mentioned. But it talks about how you can manage the difficult cases and what you should do probably when you are dealing with such a scenario. They talk about three terms which are very commonly used and very commonly confused. These include the progressive fibrotic phenotype of ILD, the progressive fibrotic interstitial lung disease, progressive pulmonary fibrosis. And they say that although these terms are all appropriate, if you consider when you see a patient initially at presentation, you risk stratify them and identify whether it's a progressive type of ILD at presentation, but none of these terms actually apply to that subgroup of non-IPF ILD patients who are already on treatment, and we see that now they are progressing. And a lot of this terminology has come from trials. So they say that because it was all evaluated in antifibrotic medication trials, they omit the defining feature, which is progression of fibrosis despite management for that ILD. So hence they said since almost 18 to 32% of non-IPF ILDs will also progress despite initial treatment within 60 to 18 months. So all of these terms, which are otherwise right terminology, will not include that particular phenotype of ILDs which are now progressing. So if you look at the term progressive pulmonary fibrosis from a perspective of progression, you will not be able to define the ones where you have to start antifibrotics because now they are progressing despite our immunosuppressant therapy. Hence, they said that it's important to distinguish between the two terms, fibrotic ILD, which is progressive pulmonary fibrosis type of ILD right from the diagnosis, and progressive pulmonary fibrosis despite management. And so they said it's important to distinguish those at first presentation who have acutely worsening symptoms, worsening imaging features, and those with worsening despite management. Because why it's important is you cannot give a free for all antifibrotic therapy for everyone who comes with fibrotic ILD, saying that it is a type of ILD which will eventually progress, because there may be certain conventional therapies, immunosuppressant therapies, that can halt the progress of the ILD. So this statement, really what it does is that when you say progressive pulmonary fibrosis despite management, you are choosing the patients where antifibrotics can be added later. And this is because ILDs are increasing, non-IPF ILDs are increasing, they are persistently progressing despite management in some cases. And so there's a lot of confusion, and sometimes wrongly so, we are giving antifibrotic therapy initially only rather than waiting for seeing the true progression. So that's basically the reason why this consensus statement has been put forth. So the first section that they talk about is the definition and the diagnosis. So if you see fibrotic ILD will be any ILD where there is fibrosis. Whether you detect this fibrosis on pathology or on radiology, you are seeing the honeycombing, traction bronchiectasis on your HRCT. This is actually a definition, fibrotic ILD, which include all the patients with any fibrosis which is observed radiologically or pathologically, however minimal. Even if it's minimal fibrosis, you see, along with other features, it is inclusive as fibrotic ILD. But certain patients where there is initially no fibrosis. So initially they don't represent fibrosis, say reticulation or ground glassing, no traction bronchiectasis. They do not represent fibrotic ILD initially. So these patients, if they progress despite their initial management with clinical, radiological, physiological indicators, despite optimal management, then these patients will be called progressive pulmonary fibrosis despite management, and these patients will be considered for antifibrotic therapy. And they say that it's estimated that over the subsequent 2 years, with adequate management, almost 40 up to 40% of non-IPF ILDs will also progress, and these will come into this terminology and this designation. Then they give us a very beautiful table of the underlying diagnosis of fibrotic ILD to really bring home the point that it's not just IPF that is fibrotic. So if you look at this, then the idiopathic variety, the IIPs, idiopathic non-specific interstitial pneumonia, cryptogenic organizing pneumonia with fibrosis, idiopathic DIP, idiopathic LIP. They all come as those ILDs where there may be fibrosis in the future. If you look at the non-idiopathic variety, then you have the connective tissue disease ILDs, the fibrotic HP, exposure-related ILDs like asbestosis, silicosis, drug-induced ILDs like amiodarone, nitrofurantoin, sarcoid, ANCA-associated vasculitis, and unclassifiable ILDs. And then they kind of further demarcate and say that if you look at the whole list, which are the ILDs you will see most likely to progress, or which patients should we really be very worried about progress? They will be idiopathic NSIPs, connective tissue disease ILDs, HP which can become fibrotic HP, sarcoidosis patients which can have progression, and the unclassifiable group. These are the group of patients where PPF despite management can occur. Now, they also give us a question. So this is answered in the form of 24 questions. So they give us a question where they ask, what is the percentage of non-IPF ILDs which progress despite the management, and what are the risk factors in these patients? So now they quote 3 studies. And these 3 studies, if you see, I have mentioned here, one was on systemic sclerosis associated ILD. The other was ILD in mixed connective tissue disease, and the third one was in rheumatoid arthritis associated ILD. So all mostly CTD ILDs. So they quote these 3 studies and say that if you look at these studies, which looked at almost 473 patients, 18 to 32% of the patients with the non-IPF ILDs will develop PPF in 60 to 80 months, as I said in my introductory slides. So in the short term, once this disease progresses, despite optimal management, we see that there will still be a risk of further progression. And this will not depend on what subtype you're seeing. If you see that they are rapidly progressing, even in short term, there's a chance this will become PPF ILD. However, in the long term, they have seen that especially in CTD ILDs like idiopathic inflammatory myositis ILD or other ILDs, some progression can be slower also. So therefore, it's important to recognize that these forms will progress and to look out for it. Now, when you talk about progressive pulmonary fibrosis and you see UIP, you know that there is a very strong risk of progression and it's a key risk factor. So, amongst the other ILDs also, once you have an accurate initial diagnosis initially to tell which ILD it is, you risk stratify them and understand that you have to evaluate for risk of progression. That is better rather than later on you are jumping onto conclusions and diagnosis and starting treatment later, because that will give you a better prognosis, a clearer communication of future risk to the patient, and a good guide to initial management. Now, this is a beautiful figure that has been given in this guideline, which represents the spectrum of ILDs that can go with progressive pulmonary fibrosis despite management. So now you can see that here the lowest and the highest prevalence that they have mentioned is given in these brackets. So 1.5 to 47. So that's the range of the risk of progression. So which one is the largest group? Obviously IPF, UIP, IPF 13 to 38% risk, but also a huge risk is in chronic fibrotic HP. Sarcoidosis is a huge risk. Unclassifiable ILD is a huge risk, and CTD ILDs. And what overlaps again is the NSIP and a little bit of drug induced and other ILDs. So if you look at this red eclipse, that represents those patients who can have progressive pulmonary fibrosis, and it takes a lot of chunk of CTD ILDs, IPAF, NSIP, chronic HP, and unclassifiable ILDs. This is the tabulated form of those risk factors which can tell you that there's a risk of progression of that non-IPF ILD into PPF. So what are these risk factors? The general risk factors are UIP. There's also BMI, which has been noted as a risk factor. So malnourished patients may have more risk of progression. Oxygen desaturation during the 6-minute walk test. Although its p-value here you see is not applicable in this study, but it has been defined as a risk factor. Then you also see, if you talk about disease, the fibrotic HP, any decline in FVC more than 10%, a lower baseline FVC, antigen identification in an HP, you know this is the antigen and you know that this patient will continue to be exposed to this antigen, so that's a risk for progression. Certain genetic variants like MUC5B gene, RAILD, where again UIP versus NSIP, high levels of CCP antibody or anti-CCP2 titers has also been studied as a risk factor. Having fibrosis on the CT and the extent of this fibrosis. When you look at systemic sclerosis, again, if your FVC is less than 65 or DLCO less than 55, if your DLCO declines more than 15%, the transfer coefficient declines more than 10%, there's a fibrosis on HRCT, the higher the score and the higher the fibrosis. So a lot of overlapping risk factors, but this really means that these patients have a more risk of progression. So why should we have an accurate initial diagnosis? Because once you have an accurate initial diagnosis, you would be able to predict that this is the risk factor, this is the diagnosis, and this is what I will do. Should I start immunosuppressives only? Should I keep him only on steroids, or should I add antifibrotics? What is a minimum initial diagnostic workup when you're looking at a patient where you think that there may be a PPF ILD? You must have a baseline HRCT, and they have really defined what you need in the HRCT as a minimum importance. You must have an end inspiratory breath hold image. You also must have an expiratory image if needed, like in HP when you're looking at air trapping. You should have thin section HRCT 1 to 2 mm. a moderate to high frequency or high spatial frequency algorithm, an inspiratory, no contrast. You can have supine and prone images and additional prone and expiratory images for monitoring if needed. And based on these, therapeutic decisions can be taken. You should have baseline LFTs. You should have, if you're doing a bronchoscopy, then BAL cellular analysis can be considered at the onset and will be very rewarding in diseases like sarcoid and HP. If HP, a precipitin screen can be done. It's not essential, but it can be done. And a baseline echo and serum NT-proBNP is justified. Why? We want to rule out other causes of breathlessness, cardiac causes of breathlessness, and coexisting core pulmonary and all in this patient. If we are doing a BAL, a lymphocytosis of less than 20% in fibrotic HP has been associated with poor prognosis and worse survival in this group of ILDs. Now, coming to the recommended autoantibody. So, this is taken from the supplementary material of this consensus statement. In routine, they've recommended that you could do anti-nuclear antibody, RF factor, ESR CRP, ROLA, so SSAA and SSB, RNP, CK, aldolase, and SCL70 antibodies. And obviously, if you are suspecting RA, then anti-CCP antibodies. The other detailed antibodies that can be done could be anti-synthetase, Jo1 and others, anti-MDA5, however, I don't think they're easily available in our country, anti-MI2, anti-NXP2, haven't seen them very frequently in most routine lab reports, anti-TIF1, anti-SRP, anti-HMGCR, SAE, U1RNP, we definitely get them in our reports, anti-PM, SCL75, you get them for polymyositis, anti-PM, SCL100, and anti-KU. If you're specifically suspecting systemic sclerosis or scleroderma, we usually go for anti-SCL70 or topoisomerase 1 and centromere. And you have the others that can be given as well. Sjogren syndrome, we know anti-SSAA or RO is positive and LA can be positive. And ANCA or anti-neutrophilic cytoplasmic antibodies when you're suspecting vasculitis like granulomatous vasculitis. Question number 6 in diagnosis is when and why should we do a biopsy? So now they say that whenever there is an absence of a typical UIP pattern on a CT, you can consider doing an interventional diagnostic procedure. But remember that has to be on a case-to-case basis. You may not need it for all the cases. Given that the identification of UIP on histology will be a major prognostic determinant, even when the confident final diagnosis of ILD cannot be made. Meaning, if you get a UIP on your histology, but you still don't know what is the cause of this UIP, you know this patient has a more risk of progression. And you may initiate antifibrotics for this patient at some point. So that is the benefit of using it. The patient should be at the center of decision making. Whenever you're choosing a diagnostic procedure, you have to explain the risk. You have to tell whether the management will be started with or without the biopsy. Will it affect your management? And a combined approach is usually beneficial. The section 2 of the consensus statement talks about prognostication and monitoring. The first question that they ask is that because we're talking about prognostication, how do you really define progression? So, progression, again, when we define it, there is no one size fits all definition. For someone in FVC, more than 10% decline may be progression, but someone without that documented decline may still have progression. So, there is a combination of respiratory symptoms, reduced lung function testing, diffusion reduction, and increasing fibrosis on HRCT, which can be used as a combination to define progression. Again, there may be patients where there may be an acute exacerbation and where we may see it as progression. So, in these cases, once the exacerbation is over, we should reevaluate the patient and maybe do an interval or follow up HRCT monitoring to see whether this patient really has a progression or he has improved after the acute exacerbation. Most of the criteria for progression have been taken from the trials, one of them largely being the inbuilt trial of nintedanib. So, in the inbuilt trial, a 10% reduction in FVC was used as a standalone inclusion criteria to say that this patient is progressing. Sometimes a smaller FVC reduction, even 5 to 10%, but along with the CT deterioration or symptomatic deterioration, can also be taken as an alternate inclusion criteria. And you could do serial HRCTs and serial PFTs to define progression, especially when one or the other data is not conclusive. So this is the inbuilt trial inclusion criteria. It's not part of the statement, but I just brought it in here for better understanding. So the inclusion criteria says that if you're saying that this patient has a chronic progressive variant of fibrosis, then what they did was they took ILDs which are non-IPF and at least had 10% fibrotic involvement of the lung on HRCT. They took patients whose FVC was above 45% and DLCO 30 to 88% of predicted. So they didn't want to take very severe cases. And those who are progressing in the last 24 months despite appropriate treatment. Exactly what this guideline is telling us. So it's similar to what the inbuilt trial was talking about. And when you define progression, the patient had to meet at least one of the criteria for progression, which was that there was a relative decline in FVC, more than 10% in the last 2 years. There was a relative decline of 5 to 10% with either HRCT increase, changes, and or a relative decline with symptomatic worsening, or just a worsened respiratory symptom and increased fibrosis on HRCT, even though the FVC may not have been documented to decline. So that was the criteria taken as per this trial. Question number 8 says, what are the patterns which suggest poor prognosis? So very clearly they said, if you use HRCT alone as a marker of progress, then that is not what you should be using. Do not use only CT to say that this patient has progressed because the CT has worsened. What should we use? CT and lung function. Because the process of follow-up CTs is gaining so much more importance, they have really highlighted this fact that they may be prognostically significant to see changes in CT. It may indicate that the disease may be progressing, but that is not a lone marker. For example, if you have reticular opacities or traction bronchiectasis with honeycombing, that may show that this patient is worsening, but you must try to establish other markers of worsening. What is the role of scoring systems for prognosis? So again, it is derived from studies. In the studies for systemic sclerosis ILD, they use CT and PFT together and derived a score for prognosis. But if you look at the other scoring systems for ILD, like the composite physiologic index, gap index, which was very frequently used in research, the gender age physiology index, they say it is of good use in research, but is it reliable on a day-to-day basis? Can they be the only markers? No. They've quoted studies by Huang et al. Where they saw that increasing honeycombing in patients with fibrotic ILD on serial CT, and they saw that over a year, and the predicted mortality was similar, even though the lung function, was not used. So even if you see a change and a progression in the CT, the predicted mortality for this patient may not be different from a patient where CT was not used. So really, alone CT should not be used. Coming to blood markers, we know a lot of blood biomarkers like KL6 have been proposed, and the consensus statement says that they do not suggest these blood biomarkers either for the diagnosis at baseline or for prognostication. Question 11. So then what should be used as an investigation for monitoring? We should use pulmonary function test. How frequently should we do them? At least 3 to 4 monthly for the first year and also beyond. So every 3 months you could call the patient for a follow up and do a PFT. If there's a decline more than 10%, it's a predictor of mortality according to many studies. If there's a lesser decline, then also the prognosis may be worse as seen in IPF studies. You could do a CT. When would you do a CT? It will be directed by the clinical context and after you see the lung function decline. So they haven't given a fixed range that do it in 6 months or 1 year. It can vary. Then majority patients will undergo a repeat CT scan, however, once a year or less. And you could do follow-up echo, follow-up NT-proBNPs and 6-minute walk test to define your progression. So it's important, like in the inbuilt trial, if we take data from that FVC progression in the placebo arm was almost identical to the FVC progression in the untreated IPFs. So FVC or lung function can be your key predictor for future progression, but you integrate it with symptomatic change and imaging change, and these are the investigations that you would perform. Question 12. Can we define an acute exacerbation of fibrotic ILD knowing that it already has fibrosis? So they say that when you talk about acute exacerbation of ILD, which is known as the symptomatic and imaging changes, new abnormalities radiologically, new ground glass, then this concept is not very clear in fibrotic ILDs. So for an acute exacerbation of fibrotic ILDs, you can say that there will be acute worsening of fibrosis that per se that may be relevant in the context of a non-IPF ILD. So that if you see more fibrosis happening, you can say that it's an acute exacerbation of fibrotic ILD, but the data is inadequate. And once you are done with acute exacerbation, you rule out that this is not drug-induced lung toxicity. You can do fresh imaging, fresh lung function test, and then define the treatment later. Coming to the third section, management of progressive pulmonary fibrosis, one-liner, no standardized management regimen that can be applied to all the progressive pulmonary fibrosis. And even the initial diagnosis depends on the ILD diagnosis. That management is determined by that and it varies according to so many factors. Question 14. Everybody wants to know, is there a benefit of adding immunosuppressants over steroids? So again, the data they say is mostly derived from studies on CTD ILDs and fibrotic HP. These are the two main diagnoses that have been studied for immunosuppressant therapy. But here again, the studies do not have a proper methodology. We still want more data. And they said that if you look at the side effects of systemic steroids, they are a concern when you give treatment for PPF. So because of that, an alternative long-term immunosuppressive agent can give you lesser side effects. So that can be initiated, but you need a case by case and disease by disease approach to assess whether it will be beneficial. And this, for example, may be worthwhile in patients with myositis or fibrotic HP. And say if you're talking about a patient with cryptogenic organizing pneumonia, which is now developing fibrosis, maybe steroids may be the better choice. So it has to be case to case. So no clear-cut answers by the consensus statement here. Next question, again very pertinent. What is the benefit of antifibrotic therapy? So they say that based on the studies done for nintedanib and pirfenidone, it has been seen that both the drugs reduce the PPF progression when they are added to the ongoing treatment or immunosuppressive therapy, like in the inbuilt trial. Yes, pirfenidone trial was prematurely stopped because of less recruitment, but it was not showing a major negative deflection. So we can say that probably both will reduce the decline. And in the inbuilt trial specifically, the FVC decline was reduced by 57% with nintedanib compared to placebo. But remember that when we're talking about the inbuilt trial, the background immunosuppression was not allowed in this trial. So they took off all the background immunosuppression except for biologics and rheumatoid arthritis. So we need more and more data, but the initial and treatment should be based on the diagnosis, whether it's steroid or immunosuppressants. And apart from IPF, systemic sclerosis, and possibly rheumatoid arthritis associated ILD, never should we consider antifibrotic as the first line. In PPF, there's more evidence that antifibrotic therapy will reduce the lung function decline regardless of the immunosuppressive therapy, as shown in the nintedanib trial. However, you should not start it initially in most cases except these three indications that I have mentioned, and we have to carefully monitor. And all of these conclusions are derived from the inbuilt and the census trial. And with more research, maybe we'll have better answers. So if we talk about the systemic sclerosis ILD and unclassifiable ILD, where pirfenidone was used along with immunosuppressant like MMF, they had actually shown that not only patients could benefit with pirfenidone, but it also had an acceptable safety profile. And in the census trial for connective tissue disease ILD, treatment with nintedanib over 52 weeks had actually shown a reduced decline in FVC. So the results are interesting, but it still needs more and more data to come as a guideline. So there's a clinical dilemma whether we should intensify the immunosuppressive therapy first, or we should introduce an antifibrotic, or we should use the combination of both. We know a lot of patients with SSC and CTD will require immunosuppression even for non-pulmonary cases. So they have left this open, and they have said that we should be having more data. So coming to what I just mentioned, combination. So they again ask themselves a question: should we give combination therapy upfront or only sequentially if there's an ongoing disease progression? And the answer that they gave is that they do not advise upfront combinations. So they say if you really need to add antifibrotics, you can do that sequentially when you're talking about PPF, and especially when we talk about PPF despite management. Sequentially adding antifibrotic after an observation period of 3 to 6 months, which determines progression despite adequate treatment, should be the way forward mostly. Addition or intensification of immunosuppressants may be done first prior to adding antifibrotics when you're dealing with CTD-ILD. Think of giving more immunosuppression rather than adding antifibrotics. And we see this so much more. Our rheumatologist colleagues are adding antifibrotic. We tell them, please intensify the immunosuppression. Don't just keep them on HCQ and methotrexate and give antifibrotics. No, kindly please increase the immunosuppression. So that's really important. In some patients, immunosuppressants may be discontinued when you are initiating antifibrotic. If you see that there has been no benefit of giving immunosuppressant and the tolerability was not good. But because there's a lack of evidence to support combinations together at the initial diagnosis, you may do the sequential therapy approach after the first 3 to 6 months. What about the tolerance and side effects? So again, they take clues from the trials. So the inbuilt, the census, and the Lotus trials show that there's no difference in the side effects reported in the antifibrotic and immunosuppressants combination therapy group compared to placebo. So that's fine. But what should we do? We must monitor the liver functions. We must monitor the hemogram. How frequently? Every month for the first 3 months, because we know with immunosuppressants also the LFTs can change with antifibrotics also. So monitor it every month for first 3 months, then every 3 months. You can do it more frequently if your patient is a liver disease patient and so on. So that is what is important. Question 18. Which one should I give, nintedanib or pirfenidone? Always a question on everybody's mind. So they have given a table and they've said that there is no head-to-head trial of nintedanib versus pirfenidone. You can't say this drug is more efficacious than the other till now based on the evidence. But if we look at the differences in the comparison, Pirfenidone will need 3 to 12 tablets. Nintedanib will need 2. Pirfenidone, the side effects will be nausea, anorexia, weight loss, rash, liver enzymes. Nintedanib, diarrhea, weight loss, and liver enzymes. Which one's better than the other? It's for the patient to see that he tolerates this more versus this more. Outdoor occupation or hobby, they say that patient with nintedanib can, because he doesn't have photosensitivity, he can continue his routine. Anticoagulation therapy, pirfenidone has a better profile with anticoagulant therapy. Ischemic heart disease, better profile. Cost, they've left a blank. Newly planned major surgery, pirfenidone probably will be better. Impact on quality of life, both. Prevention of acute exacerbations and hospitalizations, both. So, the preferred drug of choice in terms of pill burden, in terms of, say, outdoor occupations, will be nintedanib. But if you're looking at comorbidities, it's seen that pirfenidone may fare better. So, it's a cut to cut comparison, and we'll have to choose the one right for our patient. What is the treatment duration? Firstly, no evidence regarding treatment duration of combined steroids and immunosuppressive therapy in PPF. There are no trials that have been studied with combinations with steroids, with immunosuppressants, which have said that you use it for this much duration. Most people, when you have the diagnosis, you start steroid, it's already been commenced, it's been tapered, and then if it's CTD-ILD or fibrotic HP, we would again go in favor of immunosuppressants, being continued and try to take off the steroid. Specific PPFs like CTD-ILD, fibrotic HP, they say give immunosuppressants and continue. But you want to minimize the duration, you want to withdraw the steroids as soon as possible. The dose varies from patient, the duration varies from patient. But there will be certain situations when you have to give low dose steroids and keep it indefinitely continued. And these two have been defined. Number one, non pulmonary symptoms that flare on stopping the steroids, like the joint pains. Two, steroid dependency of the lung disease per se. For example, sarcoidosis. You take off the steroid and there's a decline. So you may have to continue it indefinitely. They've given a table to show the likelihood of benefit after prolonged therapy with immunosuppressants. And they say that in patients with OP pattern, NSIP, myositis ILD in young patients, patients with non-pulmonary symptoms that flare on stopping immunosuppressants, or previous objective response to steroids immunosuppressants, there's a likelihood of benefit if you continue to give them. In patients with decreased likelihood of benefit after prolonged therapy would be UIP pattern. Old patients who have recurrent infections, should you give immunosuppressants for long term or no? An absence of improvement. The last section is basically for rehab. So, number one, they ask, what is the timeline for rehab? Answer, as soon as possible. You diagnose PPF, you go ahead and ask them to start rehab. Okay. Two, it should be introduced, modulated depending on the course, because it is aiming to improve the quality of life. So, the process for referral is not like COPD. You don't wait for the exercise intolerance to set in. You go ahead and start it, and then decide the maintenance rehab on a case to case basis. And they've also mentioned the role of yoga. They mentioned the role of yogic practices in the consensus statement, like Kapalbhati, which can increase the intrathoracic pressure. They have said that if patients overdo this, they can have more barotrauma. So they can preferably avoid them. So they've kind of wholesome given a guideline that, too much is not good, too little is not good. So what is important to examine? You're sending a patient for pulmonary rehab. You see what is the severity of the disease, what is the progression of the disease, what is his perspective about rehab, what are the comorbidities, and does he have rehab centers? When you start rehab, try for a 8 to 12 week cycle. That is the bare minimum that you must give for effect to be seen. Two more things that have been mentioned is home and IV versus LTOT. So home and IV, obviously when they are in an acute exacerbation and worsening, it helps because it lowers the breathlessness, and there are clear advanced directives against invasive ventilation in a lot of these patients. So NIV really helps. However, in an actively dying patient, NIV may prolong the process of dying, and so it may not be the right choice. And here we may just give ambulatory oxygen therapy to increase mobility. So here we have to decide whether we should follow the LTOT protocol or we should give them home and IV. And patients where borderline hypoxemia is not meeting the requirements for LTOT, you can still give LTOT here due to reduction in breathlessness. But it's important to have a detailed discussion with the caregivers and decide what we are giving. Lung transplant referral, more important as more centers coming in. Transplant centers try to evaluate patients and optimize patients before you reach the end stage of lung disease. So try to refer them early so that they get enough time to evaluate, enough time to optimize them, to explain the risk, to be able to get more lungs and organs, and to address various issues like the BMI, the osteoporosis, the deconditioning, so that we have better outcomes. If you don't have a transplant, cannot refer, what do? We start treating symptomatically. The difficult to treat symptoms, we have to focus on them. So for this, we have to look at three domains. What is the lifespan of my patient, possibly? What's the quality of life? And what's the functional status? So do a lot of non-pharmacological interventions. Tell the patient to stay propped up, use relaxation techniques, physiotherapy, massages, and other things. Sometimes low dose opioids may need to be given. And in IPF patients, we've seen battery handheld fans doing wonders. They feel much better. So that something like that can also be done. So symptomatic therapy. Last question, advanced directives. Again, case to case, but start these advanced directives before the end stage. Start them immediately after the clinical decline after an exacerbation, and at the outset. Encourage it. And the goals should be discussed, the possible modalities should be discussed, and it should be discussed whether they have access to these modalities or not. So that is all for the PPF consensus guidelines. It was slightly a longer video, but it was an exhaustive consensus statement, not a guideline though. Hopefully we'll have guidelines on this. A lot of questions unanswered, but definitely they've given us more understanding as to why those questions are unanswered. And we still have to take a lot of clinical decisions on our own. So thank you very much. Happy reading. Enjoy, subscribe, like, and share. Thank you.